So good afternoon, everyone. We're going to have a little bit of liver now, which is obviously my passion, and I hope you'll realize how important this is in the setting of HIV as well. So thank you to the organizers for inviting me to present on HIV, co-infections with hepatitis B and C. Nothing to disclose. This is a brief outline of my talk. So we look at hepatitis B. In 2022, it's estimated about 254 million people are living with hepatitis B. The main burdens of disease in the Western Pacific, Africa, and Southeast Asia. But of concern, WHO Africa accounts for 66% of all new hepatitis B infections. So in 2022, it was estimated about 65 million were infected, with a prevalence of 5.8%. But of concern, only 4.2% or 2.7 million had been diagnosed, 0.2% treated, and new infections about 771,000 and 272,000 deaths. And if we look at globally, also not doing very well, 13% diagnosis coverage and 2.6% treatment coverage. But this is against the background that hepatitis B is entirely vaccine preventable. But unfortunately, only 15 WHO countries have actually implemented the birth dose vaccine. And if we look at our full birth dose full hepatitis B3 vaccine coverage, it's only 72%, well below the goal of 90%. And less than 1% of pregnant women have been screened and treated to prevent hepatitis B transmission from mother to child. In terms of hepatitis C, it's estimated about 50 million globally are infected, with the burden of disease mainly in Eastern Mediterranean, Southeast Asia, and Europe. But once again, WHO Africa has a significant burden, accounting for 51% of all new hepatitis C infections. So in WHO Africa region, about 8 million, with model prevalence of 0.7%. 172,000 new infections and 35,000 deaths. Despite having curative therapy, which really requires just 8 to 12 weeks of direct-acting antivirals, only 1 million have been diagnosed and 3% treated, doing slightly better globally at 36% diagnosis coverage and 26% treatment coverage. And then these figures we've seen throughout the meeting during the past few days. For HIV, about 40 million living globally, 1.3 have become newly infected, and about 630,000 people died from AIDS-related illnesses. But really encouragingly, 31 individuals are accessing ART. And so if we look at sub-Saharan Africa, in 2021, we still had the highest prevalence of unsuppressed viremia at 999.9 per 100,000 population, but there had been a 65% reduction between 2003 and 2021. And as we've seen, we have 26 million individuals living with HIV, and they represent over 2/3 of the global total, with women and girls accounting for 62% of all new infections. So moving now on to hepatitis B and HIV co-infections, it's estimated globally about 8 to 10% of people living with HIV have chronic hepatitis B infection, and the prevalence of co-infection varies significantly by region. It's highest in the WHO Western Pacific region at 11%, and in sub-Saharan Africa at 10%. And lowest in the regions of Europe at 0.7%, and in America at 6.7%, and in the Americas at 5.3%. So if we look at the modes of transmission, they actually vary significantly by region. So if you have a high prevalence country, the HPV transmission is mainly from mother to child or horizontal in children under the age of 5. And the rates of HIV, hepatitis B co-infection are really broadly similar across the different HIV risk groups in terms of individuals engaging heterosex, pregnant women, MSM, and people who inject drugs. In low prevalence regions, sex and injection drug use are more common modes with few reported cases of perinatal transmission. So if we look in sub-Saharan Africa, we can see that HIV and hepatitis B transmission frequently occurs independently of each other, with hepatitis B infections occurring mainly mother to child or horizontal before the age, and HIV can be acquired as adults heterosexually. But we know, and we've seen this repeatedly during the talks today, that HIV and hepatitis B can share routes of acquisition in neonates as a result of perinatal mother-to-child transmission. Importantly, maternal HIV infection increases the mother-to-child transmission of hepatitis B by 2.5-fold. As HIV promotes hepatitis B replication, these mothers are more likely to be surface antigen positive and have higher DNA levels. So in terms of how does it affect the actual natural history of hepatitis B, there are increased rates of occult hepatitis B. Adult-acquired infection, whether it's concurrently or in the setting of existing HIV, increases the risk of fulminant hepatitis. People living with HIV are 3 to 6 times more likely to develop chronic infection after an acute episode of acute hepatitis B. And hepatitis B in people living with HIV is characterized by significantly elevated hepatitis B replication. But of note, they often have, despite having this high replication, the transaminase may be only mildly elevated or even normal. There's an elevated risk of hepatitis reactivation, either reversion to surface antigen positivity or e antigen positivity. And progression to fibrosis and cirrhosis is enhanced, and there's an increased risk of HCC, tending to occur at a younger age and tends to be more aggressive. With the older regimens, as we well know, there was an increased risk of ALT hepatotoxicity, but we still have an increased risk of ALT-related immune IRS-associated hepatitis. So what about this further studies looking at the natural history? This is a large US-based cohort study looking at MSM in the era before and shortly after the advent of ART, well known to everybody, the MAX study. And here it showed that liver-related mortality amongst individuals with co-infections was 8 times higher than an HIV monoinfection and 18 times higher than hepatitis B monoinfection. Of note, liver-related mortality was highest amongst those with a low CD4 count, so individuals with CD4 count less than 200. The risk of liver-related deaths was 16 times higher than in those with a CD4 count greater than 350, and this was confirmed later in the same cohort in the ART area. ART has been shown to improve liver fibrosis in those who are co-infected, but unfortunately, hepatitis B remains a major contributor to liver-related mortality in people living with HIV from end-stage liver disease, or HCC. So in terms of this was a large observational study of 12 clinical cohorts in the North American cohort study, and they evaluated the incidence of end-stage liver outcomes amongst more than 34,000 individuals living with HIV between 1996 and 2010. And despite the substantial increases in ART activity, which was active against both HIV and hepatitis B, and high rates of HIV viral suppression amongst those receiving ART therapy, there was really no difference in the incidence rates of end-stage liver disease in individuals with co-infection amongst the early, middle, and modern ART eras. Of interest, liver-related mortality is twice as high for individuals with co-infected with hepatitis B compared to those who are co-infected with hepatitis C. So what about the impact of hepatitis B on the natural history of HIV? Here the impact is less severe. Some studies have indicated that those co-infected with HIV and hepatitis B have lower CD4 counts, and there's a potential association between adverse HIV outcomes in individuals who are co-infected has been reported. The SMART study showed that active hepatitis B replication was associated with an increased progression to AIDS-related outcomes and all-cause mortality, but this has not been confirmed in large cohort studies. Of note, if you're E antigen positive, this is associated with a slow virological response to ART compared to an E antigen negative status. So in terms of management, we've really recommended that all individuals living with HIV should be screened for hepatitis B, and ideally, depending on resources, you should have your surface antigen, surface antibody, and IgG core antibody tested. You need to vaccinate if non-immune, check the surface antibody 1 to 2 months after completing vaccination, and the different options, double dosing of the hepatitis B vaccine, combination hepatitis A and B vaccine, and then the more immunogenic vaccine, which is conjugated to adjuvant CpG, but is not freely available to us. You need to treat hepatitis B irrespective of the APRI score, the ALT, or the DNA level. And importantly, the ART regimen requires 2 agents against hepatitis B, so a combination of TDF or TAF plus FTC or lamivudine. Remembering that entecavir, which has often been used in the setting of renal impairment, although highly active against hepatitis B, has only partial activity against HIV and can produce the M184V mutation in people living with HIV if not given with a fully suppressive ART regimen. So emerging evidence is now suggesting that there's a possible advantage of TAF over TDF with regard to hepatitis B viral endpoints. This is an international, multi-central trial looking at 234 individuals with hepatitis B HIV co-infections, and participants were randomly assigned to receive either a TAF or TDF-based regimen, and were followed for 48 weeks and monitored for key HIV and hepatitis B virological endpoints. And of note, if we look at the TAF group compared to TDF, there was increased surface antigen loss, surface antibody seroconversion, E antigen loss, and ALT normalization. But HIV viral suppression and mean CD4 cell gain was comparable across both groups. And then just to remember the risk of ART interruption, we often see hepatitis B viral breakthrough before HIV viral breakthrough. This can be associated with severe hepatitis flares, increased risk of liver disease progression, mortality, and sometimes this devastating consequence of fibrosing cholestatic hepatitis. So it's important that we stage liver disease with non-invasive tests, looking at the APRI score, which looks at ALT and platelets, transient elastography if you have it. But importantly, don't forget the risk of HCC, and the patient should be screened with alpha-fetoprotein and ultrasound, and anybody who's co-infected who has cirrhosis, or if you have no cirrhosis, if your age is over 40. So moving on now to hepatitis, HIV and hepatitis C co-infections. Globally, it's estimated 2.3 million are co-infected with both infections, giving a 6.2% prevalence. The highest burden is in Eastern Europe and Central Asia, followed by Sub-Saharan Africa. And 1.3 million cases are attributed to people who inject drugs. So we looked at the study, looked at co-infection as measured by the hepatitis C antibody. It was highest in people who inject drugs at 82%, followed by MSM at 6.4%, and people living with HIV who were pregnant or heterosexually active at 4% compared to the general population of 2.4%. So globally, we now know that most new infections occur in high-risk groups, people who inject drugs or MSM, and the odds of hepatitis C infection is 6 times higher in those living with HIV compared to HIV-negative counterparts. And the very high risk are those who inject drugs, particularly with a regular drug injector, at 50 to 60%. Always remember the risk of infant born to a mother who is HIV and hepatitis C positive, where the risk is 10%, 10 to 15%, as opposed to negative less than 5%. And then in MSM, who are HIV positive and injecting drug use, the risk is as high as 10 to 15%. So we look at the routes of hepatitis C transmission in sub-Saharan Africa. They're varying routes. Iatrogenic, we still have inadequate screening of blood products in many regions. Unsafe medical injections in 2022. Globally, this accounted for 13.8%. In the WHO Africa region, 5%. Traditional scarification, and then injecting drug use. New infections globally accounted for 43.6%, and in WHO Africa, 13.5%, and this is rising. So what about the natural history of these co-infections? The viral loads tend to be 0.5 to 1 log higher, increased risk of transmission efficiency, particularly mother-to-child transmission, lower rates of spontaneous clearance of acute hepatitis B if you're co-infected at 5 to 10% compared to the usual 20 to 30%. And HIV promotes chronicity of hepatitis C, liver fibrosis, and increases HCC risk, particularly in the setting of a low CD4 count. The co-infection remains a major cause of non-AIDS-related morbidity, mortality in people living with HIV, and is associated with reduced and slower CD4 T-cell reconstitution after ART. There's no really long-term effect on clinical HIV outcomes that have been demonstrated in co-infections. And if we look at the early initiation of well-tolerated ART, together with effective direct-acting antiviral therapy, this leads to CD4 T-cell recovery, HIV suppression, and hepatitis C cure, and lowers the risk to progression to cirrhosis and HCC. And though we've seen reverse earlier trends in increased HCC incidence, and unfortunately the survival still is decreased. So what about this problem of reinfections? We need to realize the reported rates of hepatitis C infection, if you are currently active injecting drug user, is between 3.1 reinfections per 100 person years, and is highest if you are co-infected with HIV, with up to 5.7 reinfections per 100 person years. So reinfection in high-risk populations, people who inject drugs, and HIV-infected MSM are an important obstacle to hepatitis C elimination, and it usually occurs within the first 6 months of completing DAA therapy. One needs to remember that harm reduction and behavioral intervention are essential components if we're going to have successful microelimination programs, and opiate agonist therapy and needle exchange programs have resulted in a 74% reduction in new infections. It's important that one considers and always institutes retreatment of reinfections, as this is crucial to prevent ongoing transmission. And ideally, we should have biannual or at least annual testing of the hepatitis C PCR for reinfection after a DAA-induced cure. So in terms of management, unfortunately, in terms of prevention, there's no effective vaccines as yet. We need to have, importantly, implementable harm reduction programs for people who inject drugs. We need to look at our direct-acting antivirals. In fact, all patients with hepatitis C are now candidates for therapy. The individual should be stable on ART for 3 months, and HIV has had really no effect on the cure. It remains above 95%. But it is important to assess for DDIs between the DAA regimens and ART. So in terms of triple infections of HIV, hepatitis B and C, they have worse outcomes than mono and dual infections, tend to be uncommon in sub-Saharan Africa at less than 1%, but higher rates between 2 to 8% have been reported from Nigeria, Angola and Tanzania, and particularly amongst the high-risk groups of people who inject drugs. So in terms of management, they should be on stable ART, including TDF and TAF, plus lamivudine emtricitabine for 3 months, and then you initiate DAA therapy. So if we're actually going to address the problems of HIV, hepatitis B and C and co-infections, we really need to have a public health approach. We need to promote knowing your status, we need to identify high-risk groups for screening, implement effective preventative strategies with triple elimination of neonatal HIV, syphilis and viral hepatitis, aiming for greater than 90% coverage for the birth dose vaccine for hepatitis B and universal hepatitis B vaccination. Ensure that there are adequate harm reduction services for people who inject drugs, vaccinated against hepatitis B in high-risk groups, and ensure safe blood transfusion services and invasive medical practices. But ultimately, we need to improve diagnosis and linkage to care, and this will require access to point-of-care diagnostics, including hepatitis C antibody testing, and affordable access to affordable DA regimens, and sustainable access to ART. But importantly, I think we need to break down silos of healthcare, but integration will require dedicated domestic funding. Thanks.